Welcome to the Funnel Effect. Today, we are undertaking a deep dive into an area of cardiovascular medicine that is experiencing a quiet revolution: congenital heart disease in the adult population. We are specifically targeting those conditions often mistakenly labeled simple, which, well, as our sources show, is perhaps one of the most misleading terms in cardiology.
That's right, and we are building our discussion entirely around a very rich source of material, a comprehensive review titled Echocardiography in Simple Congenital Heart Diseases, Guiding Adult Patient Management.
And the list of authors on this review,
Wow.
published in the Journal of Cardiovascular Echography in 2023, it's substantial. It really reflects the immense collective knowledge required to manage these patients. Domenico Galcerano, Valeria Percola, Abdallah El Tayeb, Fulgione Ludovica, Lana Arbili, Lloyd Toshkandi, Sarah Di Michela, Agatella Barchita, Maurizio Vitaparato, and Giovanni Di Salvo. Quite a team.
It really is, and this paper provides an essential clinical roadmap focusing squarely on the diagnostic powerhouse at the center of this field: echocardiography. Okay, so let's unpack the core challenge right away, what the paper calls the paradigm shift. For decades, congenital heart disease, or CHD, was primarily seen as a pediatric concern. Why this sudden crucial focus now on adult patients?
Well, it's really because the successes of pediatric medicine have completely changed the landscape. Thanks to incredible surgical and medical advancements over the last, say, 50 years, infants and children who once had very poor prognosis are now surviving, thriving, and, well, aging. They're transitioning into adult care.
So it's a profound success story in many ways, but it creates a pretty complex management challenge for adult cardiologists who might not have trained extensively in these highly specific structural defects, right?
Precisely. The numbers themselves are quite striking. Contemporary epidemiological data indicates that approximately 1% of the adult population in developed nations is now living with some form of CHD. And that figure isn't static, it's actually poised to escalate quite rapidly.
1%.
Yeah.
That's a lot more than most people probably realize.
It is, and this group of patients needs continuous expert care, and their problems are quite unique compared to acquired heart disease.
Let's clarify what constitutes simple CHD here.
Yeah.
The paper focuses on things like atrial septal defects, ASDs, ventricular septal defects, VSDs, congenital aortic stenosis, CAS, aortic coarctation, AC, and patent ductus arteriosus, PDA. Why is simple really the wrong word to use?
It's simple in the sense that they are usually isolated defects. They don't involve multiple complex malformations, unlike, say, tetralogy of Fallot. Structurally simple, perhaps. But in the adult context, the consequences of even a simple defect, whether it was repaired decades ago or perhaps left untreated, or anything but simple, they demand lifelong, highly specialized management.
And the cost of neglecting that management, what are we looking at?
We're looking at substantial morbidity and mortality down the line. We're talking about progressive heart failure, the development of serious complex arrhythmias, and also the ever-present risk of infective endocarditis.
So the defect itself might be structurally straightforward, but its hemodynamic and electrical implications, they just compound exponentially over 40 or 50 years of adult life.
Exactly. That's the crux of the issue.
Okay, that really sets the stage. So if lifelong management is the absolute necessity here, then our tool for surveillance must be incredibly reliable, non-invasive, and dynamic. And that brings us right back to echocardiography, the star of this review.
It really is the undisputed champion in this area. Echocardiography, or echo, serves as the primary non-invasive imaging modality. Its strength is that it moves well beyond just taking static anatomical snapshots.
Right, it's not just a picture.
No. Its power is derived from its ability to visualize dynamic shunt dynamics, the incorrect flow of blood between chambers or vessels, and accurately quantify key hemodynamic parameters, things like pressure gradients, flow volumes.
And that precision is essential for clinical decision-making, for prognostication, and for robust risk stratification, isn't it?
Absolutely. It guides everything.
So let's unpack what precision-guided really means in practice. If a general cardiologist relies on a standard echo, what specific high-resolution details are required in the CHD population that elevates echo to this specialized status? What's the extra layer?
It's really the multifaceted data stream you get. High-resolution visualization is key, of course, looking at the exact size, the spatial orientation of the defect, mapping out flow patterns with color Doppler. But it's also about assessing the mechanical dynamics of the cardiac structures.
Okay.
Critically, these quantified insights then directly inform tailored therapeutic strategies. Let's say a patient is developing heart failure 40 years after their initial repair. We need to know the exact chamber dimensions, the flow velocities across valves or patches, the pressure gradients. Is the issue residual pressure load? Is it volume load? Or is the ventricle itself just failing? Echo helps us figure that out.
So it's definitely not just a screening tool then. It's more like the GPS for long-term management. But thinking about those decades of chronic pressure or volume overload, that must lead to extremely subtle changes in the heart muscle itself. Can standard imaging really pick up these minute but prognostically vital struggles?
Often no. Traditional methods, like just looking at ejection fraction, often miss the earliest signs of myocardial strain or dysfunction. And that's precisely why the integration of advanced techniques is becoming, well, non-negotiable in specialized centers. We're talking particularly about tissue Doppler imaging, TDI, and speckle tracking echocardiography.
We hear these terms thrown around a lot, TDI and speckle tracking. For the listener, maybe break down what they're actually measuring that the basic color flow or 2D image is failing to capture.
Okay, so TDI essentially measures the velocity of the heart muscle's motion directly. It gives you good insights into how fast different segments of the tissue are moving, which relates to relaxation and contraction speeds.
And speckle tracking.
Speckle tracking is maybe even more revolutionary. It actually tracks specific acoustic markers, these speckles you see within the myocardium on the 2D image, as the heart beats. By tracking their movement relative to each other, it calculates deformation, which we call strain.
Strain.
Yeah.
Like how much the muscle is stretching or compressing.
Exactly. This provides incredibly nuanced insights into things like atrial mechanics, diastolic function, which is the heart's critical ability to relax and fill properly, and overall ventricular filling kinetics. It's looking at the muscle function itself, not just the chamber volume changes.
Ah, okay, so that sounds like really crucial information. If a standard echo tells you the left ventricle is still pumping at a decent amount of blood, the strain rate analysis could tell you how efficiently each regional segment of that ventricle is actually contracting and relaxing to achieve that output.
Precisely. It moves us from a sort of gross assessment of the pump, like the ejection fraction, to a much more granular regional analysis of the muscle tissue's intrinsic function. This offers a profound understanding of these ventricular diastolic interactions.
And for an adult who's been living with a chronic high-pressure condition for decades.
For them, understanding how the RV or LV is struggling under that long-term stress, which might present initially as subtle diastolic impairment years before the systolic function drops, is absolutely vital for preemptive intervention, catching it early.
Okay, let's use that precision lens then to start diving into the specific conditions mentioned in the review. We can begin with a structural problem that really defines risk. Congenital aortic stenosis, or CAS. So CAS is fundamentally a physical narrowing or malformation of the aortic valve, the valve controlling blood exit from the main pumping chamber, the LV. What are the key structural variations we need to be mindful of here?
Right. CAS involves structural abnormalities that prevent the valve leaflets from opening properly. The most common manifestation by far is the bicuspid aortic valve, or BAV, where the valve has only 2 leaflets instead of the normal 3.
BAV, yeah, that comes up a lot.
It does. But we also see quadricuspid valves with 4 leaflets and even unicuspid morphologies with only 1. Those are much rarer, though. And the clinical spectrum really mirrors the mechanical severity of the narrowing. It can range from completely silent incidental findings on an echo all the way to severe symptomatic cases involving exertional dyspnea, chest pain, and even syncope or fainting.
And the diagnosis itself isn't really enough, is it? It's the severity quantification that dictates whether and when intervention is needed. How does Doppler imaging establish that crucial threshold for severe stenosis?
Echocardiography is definitely the first-line examination for diagnosis and characterization. But yes, Doppler is the absolute key for quantification. It uses ultrasound principles to measure flow velocity and calculate pressure gradients across the valve, effectively measuring the resistance caused by that narrow opening.
Let's nail down the specific cutoff values provided in the source materials table 1, because these numbers are often the tipping point for deciding on valve replacement or other interventions.
Okay. Severe stenosis is pretty rigorously defined by a convergence of 4 key hemodynamic parameters. First, and perhaps most critically, the calculated aortic valve area, or AVA, needs to be less than 1.0 square centimeter. That's quite a small opening.
Less than 1.0 centimeters squared.
Second, the peak aortic jet velocity, that's how fast the blood is accelerating as it shoots through that tiny opening, needs to be greater than 4.0 meters per second.
4 meters per second? That's fast.
Very fast. Third, the mean pressure gradient across the valve, the average pressure difference between the LV and the aorta during ejection, must be greater than 40 millimeters of mercury.
Okay, 40 millimeter G mean gradient.
And finally, there's the dimensionless index, or DI. This is a ratio comparing the velocity through the LV outflow tract to the velocity through the aortic valve itself. A DI of less than 0.25 also indicates severe stenosis.
I want to pause on those 4 metrics for a second. Why do we need all of them? Can't we just rely on the aortic valve area, the AVA?
That's a great question. We use all 4 because they account for different physiological variables and potential confounders. AVA is critical, yes, but its calculation can be subject to measurement error, and it's also dependent on the flow state.
Meaning if the heart is pumping weakly?
Exactly. If you have low cardiac output, the pressure gradient and even the peak velocity might be deceptively low, even if the valve itself is very stiff and significantly narrowed. This is the concept of low flow, low gradient, severe AS. So, relying on the convergence of all 4 metrics provides robustness and internal cross-validation. It helps ensure we don't intervene too early or, just as importantly, miss a severe case that might currently be low flow or asymptomatic.
That makes a lot of sense. Now let's delve into the complexities of the bicuspid aortic valve, the BAV. The source suggests that BAV isn't just one disease, but actually many, depending on the specific fusion pattern of the cusps. And this apparently has profound prognostic implications.
Yes, this is one of the really fascinating points highlighted in the paper, and it underscores why precision imaging is so vital. They reference a meta-analysis by May and colleagues, which detailed how the specific phenotype, basically, which 2 cusps fused together during development, actually drives the patient's long-term risk profile for different types of valve dysfunction.
Okay, tell us about the 2 main fusion patterns discussed and how their futures seem to diverge.
The primary patterns are BAV with fusion of the right and left coronary cusps, that's called RL fusion, and BAV with fusion of the right and non-coronary cusps, called RN fusion. What's striking is how their clinical destinies differ.
How so?
The meta-analysis found that patients with the BAV-RL phenotype exhibited a significantly higher incidence of developing aortic regurgitation over time. That's where the valve leaks blood backward into the left ventricle. So it tends to be more of a volume overload problem for the LV.
Okay, RL fusion linked to regurgitation.
And the RN pattern. Conversely, patients with the BAV-RN fusion pattern displayed a lower incidence of significant aortic stenosis initially, but they seem to be more predisposed to developing progressive AS, the narrowing over the long term.
Wow.
So the specific anatomy seen on the echo can actually help predict whether the cardiologist should be more vigilant about monitoring for a volume problem, like regurgitation, or a pressure problem, like stenosis, years before either becomes hemodynamically critical.
That's a huge difference in monitoring strategy and potentially even prophylactic treatment down the road. For the patient, this means their individual risk profile is literally written into the structure of their valve, visible only through high-resolution echo. The source also highlighted the presence of something called a ROFE. What role does that small ridge play?
Right, the raphe. It's essentially a residual, underdeveloped ridge of tissue found at the line where the 2 cusps fused. The meta-analysis found that the presence of a raphe correlated specifically with an elevated risk of developing aortic regurgitation.
But not stenosis.
Interestingly, no. The analysis showed the RAF did not seem to influence the risk of stenosis development, so this is a highly specific finding. If an echo identifies a patient with a BAV and a visible RAF, the imaging specialist knows to be particularly vigilant about monitoring for progressive valve leakage, regardless of the patient's age or current gradient.
So how does all this incredibly detailed surveillance translate into actual treatment decisions?
It informs every single step. Echocardiographic surveillance, using these parameters, monitors the progression of both stenosis and regurgitation over time. This guides the timing and type of therapeutic strategies, whether that's medical management initially, or eventually surgical valve replacement, or perhaps transcatheter valve implantation, ADI. It ensures timely intervention before irreversible damage occurs.
And it's useful even in complex surgeries.
Absolutely. For instance, the review mentions the Ross procedure, a complex operation where the patient's own pulmonary valve is moved to the aortic position and a donor valve is placed in the pulmonary position. The preoperative echo assessment of the native pulmonary valve's structure and function is absolutely critical for selecting appropriate candidates and maximizing the chances of a favorable long-term outcome.
Okay, so if CAS is fundamentally a pressure problem originating at the valve level, let's shift our focus now to a pressure problem that occurs further down the line on the main vessel itself, aortic coarctation, or AC.
Right, aortic coarctation is a localized narrowing, a constriction of the aorta itself.
Hmm?
Typically, it's situated just distal to or just beyond the origin of the left subclavian artery, near where the ductus arteriosus used to be in fetal life.
That kind of constriction in the body's main artery must create a pretty drastic pressure differential throughout the circulation. What are the key hemodynamic consequences we see?
You're right, the narrowing acts almost like a dam. You get increased pressure proximal to the coarctation, so in the upper body, arms, and head. This forces the left ventricle to work much harder against this elevated resistance, this afterload. Over time, this leads to left ventricular hypertrophy. The LV wall thickens significantly.
Downstream, below the narrowing.
Distally, beyond the constriction, the pressure is dramatically reduced. So blood pressure in the legs and lower body can be significantly lower than in the arms.
And that pressure disparity is exactly what we often see clinically, resulting in some classic physical signs, isn't it?
Exactly. The most prominent result is hypertension, often very severe, specifically in the upper extremities. And this often contrasts with that lower pressure in the legs. Clinically, this can manifest as diminished or even absent pulses in the lower extremities, sometimes referred to as the brachial femoral delay or pulse discrepancy.
Just as with CAS, there must be specific echo and clinical cutoffs that signal the severity of the coarctation and point towards the need for intervention, like surgery or stenting. What are those key signposts from Table 2?
Yes, the threshold for defining hemodynamically significant AC relies on a few main markers. First, looking directly at the coarctation site with Doppler echo, a peak gradient across that narrowed segment greater than 20 millimeters of mercury generally indicates a clinically significant obstruction.
Okay, peak gradient 20 millimiller Hg.
Second, there's the clinical correlation, measuring blood pressure in both the arms and legs. An arm-leg blood pressure gradient that exceeds 20 millimiller Hg is another strong indicator of severity.
Right, the direct pressure difference.
And third, there's a useful quantitative measure derived from Doppler velocities. The velocity ratio comparing flow just after the coarctation site to flow just before it. A ratio below 0.67 is generally considered indicative of severe coarctation.
That velocity ratio seems quite objective. It's directly comparing the speed of blood flow before and after the pinch point, essentially.
It is. It helps to standardize the measurements somewhat and can account for variations in overall cardiac output. A low ratio strongly suggests a significant pressure drop across the obstruction because the flow has to accelerate so much through the narrow segment.
Now, the body's pretty amazing at compensating, isn't it? It often finds ways to bypass such an obstruction. How does echocardiography help us visualize these compensatory mechanisms that might actually mask the true severity if you only looked at leg pressures?
That's a really critical role for echo, especially using color and pulsed wave Doppler. Echo can visualize the exact site and the extent of the AC itself, but just as importantly, it helps detect the presence and assess the flow patterns within collateral vessels.
Collateral, like natural bypass artery.
Essentially, yes. These are typically intercostal and internal mammary arteries that enlarge over time to create alternative pathways for blood to get around the blockage and supply the lower body. If a patient has a very severe anatomical coarctation but has developed massive collateral circulation, their lower body blood pressures might actually seem deceptively adequate.
So detecting these collaterals is fundamental for accurately assessing the true native severity of the coarctation and understanding the patient's overall hemodynamic state beyond just the arm-leg pressure difference.
Absolutely. It tells you how much the body is relying on these alternative routes.
Okay, now here's the point in the source material that really grabbed my attention. The discussion about persistent issues even after repair. It seems even after a seemingly successful surgical correction or stenting, the heart and vessels don't necessarily return to a completely normal baseline.
Yes, this is a somewhat sobering reality for many types of repaired CHD, including coarctation. The long-term studies cited in the review show that even years after successful intervention, patients often exhibit persistent abnormal regional myocardial deformation properties when assessed with techniques like strain imaging. They also tend to have increased aortic stiffness compared to controls.
So even if the main obstruction is fixed and the blood pressure normalizes, the vessel wall damage and the remodeling of the left ventricle, that thickening caused by decades of fighting high pressure, they don't seem to fully reverse.
That seems to be the case for many patients. The LV muscle tissue appears to retain a kind of memory of that high-pressure existence, manifesting as subtle functional and structural abnormalities.
And this memory presumably means the patient is still at an elevated long-term risk for things like premature heart failure or arrhythmias, even if their resting blood pressure looks good.
Exactly. And the source even noted an interesting finding that obesity can further compound this issue, potentially impacting LV geometry and function negatively, even in pediatric patients after their coarctation repair. It adds another layer of risk.
So what's the big implication here for long-term monitoring? It definitely sounds like relying solely on checking blood pressure or looking at a standard ejection fraction might not be enough for these patients.
It really seems insufficient for comprehensive risk assessment. The studies focusing specifically on normotensive post-repair patients, those whose blood pressure is now considered normal, still showed these persistent abnormalities in regional myocardial deformation using strain imaging.
So even with normal BP, the muscle isn't quite normal.
Right. This emphasizes the critical need for incorporating these advanced techniques like strain rate imaging into the routine follow-up protocols to comprehensively assess long-term cardiovascular health. If we only treat the hypertension symptomatically but ignore underlying myocardial stiffness or dysfunction detected by strain imaging, we might be missing a crucial part of the patient's ongoing pathology and risk.
And this likely drives ongoing medical management too, right? Knowing about this persistent underlying risk must inform the choice of antihypertensive medication, for example.
Absolutely. The review touches on research aimed at optimizing medication choices for managing post-repair hypertension. It's not just about lowering the pressure number, it's about potentially choosing agents, like comparing beta blockers, atenolol versus ACE inhibitors, enalapril, that might have more favorable effects on reversing or stabilizing that residual myocardial remodeling and aortic stiffness. The surveillance needs to be sophisticated and ongoing.
Okay, we've tackled two major pressure problems, CAS and AC. Let's pivot now to a classic volume problem. Patent ductus arteriosus, or PDA.
Right, the PDA. This is a developmental anomaly where the ductus arteriosus, which is a normal and essential blood vessel in the fetus that shunts blood away from the non-functional lungs directly into the aorta, fails to close naturally shortly after birth as it's supposed to.
And once it remains patent or open in infancy or childhood, it creates a pretty significant flow issue, primarily because the aorta is a high-pressure system, and the pulmonary artery into which it connects is normally a low-pressure system, right?
Exactly. The fundamental consequence is a continuous shunt of oxygenated blood flowing from the high-pressure aorta back into the lower-pressure pulmonary artery. This pathologically increases the volume of blood flowing into the lungs.
And that extra volume then has to come back to the left side of the heart.
Precisely. It overloads the pulmonary veins, the left atrium, and ultimately the left ventricle. The entire left side of the heart is forced to handle significantly more volume than it should.
And that cascade of chronic volume overload is what leads to the long-term adult complications we worry about, isn't it?
Yes, over years or decades. The left ventricle undergoes dilation and hypertrophy specifically due to this volume overload. This can lead to chronic pulmonary congestion, symptoms of fatigue and breathlessness, and eventually overt congestive heart failure. And if the shunt is large enough for long enough, it can also lead to the dangerous complication of pulmonary hypertension as the lung vessels remodel.
Now, the classic presentation of a significant PDA in an infant is usually pretty clear, often with a characteristic murmur. But how does the adult presentation differ, especially regarding the shunt dynamics themselves?
That's a key point the review makes, referencing work by Fable and colleagues. In adults, the presentation can often be much more subtle initially. Maybe just chronic shortness of breath on exertion or increased fatigue, or sometimes it's picked up because of that increased risk of infective endocarditis on the abnormal vessel. But the fundamental difference often lies in the shunt profile itself.
How did the dynamics change so drastically from infancy to adulthood?
Well, it's because the pulmonary vascular pressures are not static over a lifetime. While infants with a PDA typically exhibit a classic left-to-right shunt, from aorta to pulmonary artery, adults can present with much more diverse hemodynamic profiles. You can see L to R shunts, yes, but also sometimes bidirectional shunts or even predominantly right to L shunts.
R to L meaning the flow is reversed.
Exactly. This variation results from complex interactions between the systemic arterial pressure and the resistance that may have built up in the pulmonary vasculature over decades due to the chronic volume overload.
An Arter-Wells shunt sounds like a particularly grave finding. It must signal that pulmonary hypertension has become so severe that the pressure in the pulmonary artery now actually exceeds the pressure in the aorta, reversing the direction of flow through the PDA.
Precisely that. Discovering predominant R to L flow completely changes the patient's prognosis and, critically, the therapeutic approach. Intervention to close the PDA in a patient with established severe pulmonary hypertension and an R to L shunt, Eisenmenger syndrome, is generally contraindicated.
Why is that?
Because closing that PDA, which is now acting as a pop-off valve, would acutely increase the pressure load on the already failing right ventricle, potentially causing catastrophic RV failure. So echocardiography absolutely must delineate these precise hemodynamic shunt profiles to guide management safely.
So, how does echo quantify the significance of the shunting in a PDA? Beyond just seeing the jet with color Doppler, what specific numbers or findings tell clinicians that this PDA requires attention, potentially closure?
Color flow Doppler is great for visualizing the tubular connection and the shunt jet itself, but we rely on specific quantitative parameters outlined in Table 3 of the review to define clinical significance, especially for L to R shunts.
Okay, let's define those key parameters.
First, calculating the ratio of pulmonary blood flow to systemic blood flow, known as QPQs. If the QPQ's ratio is greater than 1.5, it generally indicates a hemodynamically significant shunt. It means at least 50% more blood is circulating through the lungs than through the rest of the body.
QPQ is 1.5. Got it. What else?
Second, we look closely at the flow pattern in the descending aorta using pulsed wave Doppler. The presence of significant retrograde diastolic flow in the descending aorta is a crucial sign. It implies that a substantial volume of blood that should be going systemically down the aorta is instead being stolen or diverted back through the PDA into the pulmonary circulation during diastole.
Okay, retrograde flow in the descending aorta. And the third marker relates to pressure half-time.
Yes. Using continuous wave Doppler across the PDA jet, we can measure the rate at which the pressure gradient declines during diastole. A shorter pressure half-time, PHT, signifies a larger, less restrictive shunt. Basically, the pressures equalize more quickly because the hole is bigger.
I see. So these three markers, QPQs 1.5, retrograde diastolic flow in the aorta, and a short PHT taken together, are how clinicians discriminate between perhaps a small, hemodynamically benign PDA that can just be monitored, and a more significant one that is actively contributing to volume overload and likely needs closure, either percutaneously or surgically.
That's the essence of it, yes. It's about quantifying the hemodynamic impact.
All right, we've covered defects in the major arteries, the aorta and the pulmonary artery connection via the PDA. Let's move now to defects within the heart chambers themselves, starting at the atrial level. Atrial septal defects, or ASDs.
Okay, ASDs. These are essentially holes or communications between the two upper chambers of the heart, the right atrium and the left atrium. And crucially, ASDs are not a single entity. The review emphasizes there are 4 distinct anatomical types based on their location within the atrial septum, and each type can have different anatomical associations and implications for closure.
Let's clearly define those 4 types, perhaps starting with the most common one.
The most common type by far is the secundum ASD. This is typically located in the central part of the atrial septum near the fossa ovalis, and it usually results from the incomplete closure of the foramen oval after birth. These are often isolated defects, meaning they aren't typically associated with other major heart problems.
Okay, secundum ASD central, common, often isolated. What's next?
Next is the primum ASD. This type is located in the lower part of the atrial septum, close to the atrioventricular valves, the mitral and tricuspid valves. Primum ASDs are structurally a bit more complex because they often result from what are called endocardial cushion defects during development. Because of this, they are frequently associated with abnormalities of the mitral valve, most commonly a cleft in the anterior mitral valve leaflet.
So the complexity increases significantly with the primum defect because you might be dealing with 2 issues simultaneously, the hole itself and a potentially leaking mitral valve due to the cleft.
Exactly. Repair often involves addressing both the septal defect and the mitral valve abnormality. The third type is the sinus venosus defect. These are typically located higher up in the septum, near the junction where the superior vena cava, SVC, enters the right atrium, or sometimes lower down near the inferior vena cava, IVC junction.
And these are known for being associated with another problem.
Yes, Sinus venosus ASDs are notorious because they are frequently associated with partial anomalous pulmonary venous drainage, PAPVD. This means one or more of the right pulmonary veins, which should drain oxygenated blood into the left atrium, instead drain incorrectly into the right atrium or vena cava. This adds an additional layer of right-sided volume overload on top of the shunt through the ASD itself.
So more complex hemodynamics again, and the rare fourth type.
The rare fourth type mentioned is the unroofed coronary sinus, UCS defect. This is quite uncommon. It occurs when there's a defect or absence in the wall and the left atrium. This creates a communication allowing shunting, usually from left atrium to coronary sinus right atrium. It's often diagnosed definitively by injecting agitated saline contrast during an echo and watching the path of the bubbles.
Interesting. Okay, so regardless of the specific anatomical type, the primary hemodynamic impact of most significant ASDs is chronic volume overload, but this time primarily on the right side of the heart, correct?
Correct. Because pressure in the left atrium is normally slightly higher than in the right atrium, blood shunts from left to right across the ASD. This causes chronic volume expansion in the right-sided chambers. The right atrium and the right ventricle become dilated over time.
And that long-term right-sided volume overload leads to the clinical complications we see in adults.
Yes, eventually. This can manifest as debilitating fatigue, shortness of breath, exercise intolerance, palpitations due to stretching of the right atrium leading to atrial arrhythmias like atrial flutter, or, very commonly, atrial fibrillation, which is a major long-term risk factor for stroke. And ultimately, if left unmanaged, the increased pulmonary blood flow can lead to pulmonary hypertension as the pulmonary vascular resistance increases over decades.
This seems like another area where those advanced imaging techniques like strain really come back into play. The source references strain rate imaging studies that have actually confirmed the functional benefits of closing these defects. What specific functional gains did they document?
Yes, those studies provided powerful objective validation for intervention, especially in adults who might be minimally symptomatic. They used techniques like speckle tracking strain to demonstrate that both surgical and percutaneous device closure methods led to significant functional improvement, not just structural closure.
How so?
By measuring atrial strain and strain rate parameters before and after closure, researchers showed enhanced mechanical performance of the atrium itself post-closure. The right atrium and even the left atrium started contracting and relaxing more efficiently once the volume overload was relieved. This proved that closing the shunt wasn't just passively decompressing the right ventricle, it was actively improving the intrinsic mechanics of the receiving atrial chambers.
And did those benefits extend beyond just the atria? Did ventricular function improve too?
Yes. The source indicated that these atrial functional improvements also signified improved overall ventricular mechanics post-closure. Relieving that decades-long volume strain on the right ventricle allows its myocardial fibers to recover somewhat and function more normally, which could be tracked with RV strain measurements. This objective functional improvement is often the crucial data point that justifies recommending intervention in adults, even if their symptoms are currently mild.
So based on all that, what are the primary indications echo helps establish for deciding to actually close an ASD in an adult patient?
The key indications really revolve around objective evidence of significant shunting and its consequences, alongside clinical symptoms, if present. Specifically, echo is used to confirm a significant shunt magnitude, usually defined by that QPQ's ratio being greater than 1.5.
Okay, QPQ's 1.5 again.
Yes. Another key echo marker is evidence of right ventricular volume overload, typically defined as the right ventricular end diastolic diameter being larger than the left ventricular end diastolic diameter, an RVLV diastolic ratio 1. If these objective markers of significant shunt and RV volume overload are present, closure is generally recommended, especially if the patient also has related symptoms like decreasing exercise tolerance, documented arrhythmias, or even paradoxical embolism.
Right, preventing clots from crossing over. Okay, we've moved across the atria. Let's now tackle what might be considered the most hemodynamically stressful of these simple defects because of the huge pressure difference involved. Ventricular septal defects, or VSDs.
Right, VSDs. These are openings or holes in the interventricular septum, the wall dividing the two main pumping chambers, the ventricles. And you're right, they are potentially the most acutely consequential of these simple defects, simply because the pressure differential between the high-pressure left ventricle and the much lower-pressure right ventricle is so immense during systole.
And just like with ASDs, there's crucial anatomical variation based on location that dictates the complexity and often the approach to closure, isn't there? What are the main types of VSDs?
Yes, the location is key. VSDs are generally classified by their anatomical position within the septum. You have muscular VSDs, which are located purely within the thick muscular part of the septum, sometimes multiple. Swiss cheese septum. Then there are membranous VSDs, which involve the thin, fibrous membranous septum near the central fibrous body of the heart.
And the most common type?
The most common type in most series is the perimembranous VSD. These are situated adjacent to the membranous septum, but often extend into surrounding muscular tissue near the hinge points of the tricuspid and aortic valves. Their proximity to these vital valve structures makes closure, particularly transcatheter closure, more challenging.
Okay, and the last type?
Finally, there are the doubly committed subarterial VSDs, also called supracrystal or outlet VSDs. These are located high in the septum, immediately beneath both the aortic and pulmonary valves. A particular concern with these is the risk of associated aortic valve prolapse and progressive aortic regurgitation due to lack of support for the right coronary cusp.
Let's detail the severe hemodynamic repercussions caused by that extreme pressure differential and the resulting left-to-right shunting across a significant VSD. What happens?
During systole, when the LV contracts forcefully, oxygenated blood is shunted at high velocity from the high-pressure left ventricle back into the lower-pressure right ventricle. This generates profound volume overload primarily on the right heart structures.
So the RV gets hit hard.
Yes, the RV has to handle its normal venous return plus this extra shunted volume. This leads to RV dilation, often RV pressure overload as well if the shunt is large, eventually RV hypertrophy, and significantly increased pulmonary blood flow. This dramatically accelerates the risk of developing irreversible pulmonary vascular disease and pulmonary hypertension compared to an ASD.
And the left ventricle, the source of the high pressure in the shunt flow, it also suffers consequences, doesn't it? Even though it's shunting blood away initially.
It absolutely does, primarily due to volume overload during diastole. The LV has to accommodate the normal systemic venous return coming from the lungs, plus all the extra blood volume that was shunted into the RV, went through the lungs again, and then came back to the left atrium and LV.
So it's like doing double duty.
In a sense, yes. This leads to progressive LV dilation and what's called eccentric hypertrophy, where the chamber enlarges more than it thickens. While initially a compensatory mechanism to maintain cardiac output, this prolonged volume overload eventually exhausts the ventricle, leading to systolic dysfunction and heart failure.
Echocardiography, therefore, must be doing a lot of heavy lifting here. It needs to visualize the defect size and location, quantify the shunt flow, and assess the pressure dynamics involved.
Precisely. 2D imaging helps estimate the anatomical size and location. Color Doppler is crucial for visualizing the shunt jet, its direction, and getting a qualitative sense of the flow volume. But continuous wave, CW Doppler, becomes indispensable for quantifying the pressure gradient.
How does CW Doppler do that?
By measuring the peak velocity of the blood jet shooting across the VSD, we can use the simplified Bernoulli equation, pressure gradient equal 4 velocity, to accurately estimate the pressure difference between the LV and the RV. This calculation gives clinicians a profound understanding of the hemodynamic relevance and severity of the shunt. A high-velocity, high-gradient jet usually implies the RV pressure is still low, a restrictive VSD, while a lower velocity might indicate either a very large non-restrictive defect or, more ominously, rising RV pressures due to developing pulmonary hypertension. The gradient is often more important than the simple anatomical size of the hole in determining significance.
Now, the source material highlighted an absolutely extraordinary example of how precision imaging can lead directly to personalized intervention strategy. It discussed the Singh-Sivakumar classification system specifically for perimembranous VSDs. This sounds like taking intervention guidance to the absolute cutting edge.
It really is a fantastic example of specialized adult and pediatric CHD management in action. This classification system, developed by Singh and Sivakumar, categorizes perimembranous VSDs, again, the most common type, into 4 distinct anatomical groups based on their relationship to the aortic valve. The whole purpose is to guide the selection of the ideal transcatheter occluder device for that specific anatomy, thereby minimizing the risk of complications like device embolization, residual shunts, or damage to the nearby aortic or tricuspid valves.
Okay, walk us through how this classification works. Why does the specific anatomy dictate a different type of closure device for each group?
It's all about the specific margins of the defect, particularly the rim separating the VSD from the aortic valve. Group A defects are characterized as being without a significant aortic margin or having only a very thin one. Because there's less tissue supporting the device away from the aortic valve, an asymmetric device is often recommended. This device has a larger disc on the LV side to anchor securely and a smaller profile on the RV side to minimize interaction with the tricuspid valve.
Okay, Group A needs an asymmetric device. What about Group B?
Group B VSDs are defined by having a thick, muscular aortic margin separating the defect from the aortic valve. This substantial rim provides good structural stability. Therefore, robust, often symmetric devices like the Amplatzer duct occluder I, ADOI, or a muscular ventricular septal occluder, MVSO, can often be used safely, as the thick margin helps protect the aortic valve leaflets from impingement by the device.
Makes sense. Now, what specific complication is the classification trying to prevent by its recommendation for Group C defects?
Group C defects are those associated with the formation of a membranous septal aneurysm, basically. The thin membranous septum near the VSD has bulged out into an aneurysm sac. Because this tissue is already compromised, stretched, and potentially fragile, the recommendation shifts towards using a device with a thinner profile and perhaps less radial force, specifically mentioning the Amplatzer duct occluder 2, ADOII, in the review. The goal is to minimize stress on that already weakened aneurysmal wall during and after device deployment.
Clever. And finally, Group D. What's the anatomical challenge there?
Group D defects are anatomically restricted, not by the aortic valve, but by attachments or chordae from the tricuspid valve apparatus that adhere to the margins of the VSD. Here, the ADOI device, Amplatzer duct occluder 1, is often recommended again. Its specific design, particularly the shape and size of this RV retention disc, is thought to minimize the risk of interfering with the delicate tricuspid valve function in these anatomically constrained situations.
That level of anatomical specificity derived purely from imaging is just astounding, using Echo to decide between 4 different physical device profiles to optimize safety. Did this classification system actually lead to demonstrably better outcomes in their experience?
According to the review citing the original work, the outcomes were indeed compelling. Implementing this tailored imaging-guided approach resulted in successful transcatheter closures across all 4 groups. And importantly, the long-term follow-up, which extended beyond 7 years in their cohort, reported 0 instances of significant late complications, like device-induced aortic regurgitation or complete heart block.
Wow, 0 late complications.
Yeah, it really provides strong evidence that leveraging these specific imaging-derived anatomical insights truly optimizes patient safety and improves long-term results for percutaneous VSD closure. It's precision medicine in action.
Absolutely. Now that we've established just how intricately imaging guides these structural interventions, let's maybe zoom out slightly to look at the broader, more fundamental issue in managing adult CHD patients. Assessing how well the heart muscle itself actually works, its systolic and diastolic function. #Tag7. Assessment of systolic and diastolic function in CHD.
Yes, this is crucial. We have to remember that these patients have often spent decades, sometimes their entire lives, living with abnormal loading conditions, either chronic pressure overload or chronic volume overload, or sometimes a combination. So when we come to assess their heart's function, simply relying on traditional metrics like ejection fraction, EF, can often be limited, even misleading.
Why is the standard ejection fraction potentially unreliable in the CHD population, especially when it's considered the global standard for assessing function in non-CHD heart failure?
Well, it's because EF, which measures the percentage of blood pumped out of the ventricle with each beat, is highly dependent on both preload, the volume filling the ventricle, and afterload, the resistance the ventricle pumps against. So think about a patient with a large left-to-right shunt, like a big ASD or VSD. The volume returning to the left ventricle, preload, is significantly augmented by that shunted blood recirculating through the lungs. This high preload can artificially boost the calculated ejection fraction, making the LV function look normal or even hyperdynamic, even if the underlying myocardial contractility, the muscle's intrinsic strength, is actually starting to fail. EF simply doesn't always reflect the true contractile health of the muscle in these altered loading states.
Ah, I see. The chamber is ejecting a high percentage, but only because it was overfilled to begin with.
Exactly. Conversely, in severe pressure overload states like aortic stenosis, the EF might drop late only after significant damage has occurred. So we absolutely must rely on those newer, more nuanced techniques we discussed earlier to get a better sense of the true contractility.
So techniques like strain imaging become indispensable here too.
Absolutely. Techniques that measure myocardial deformation directly, like speckle tracking strain, or even simpler measures like fiber shortening derived from M mode, become really valuable. They provide more objective, relatively load-independent insights into the intrinsic myocardial contractility and can reveal regional functional details. They allow us to see subtle deterioration long before the global EF drops significantly.
And the review mentioned color Doppler TDI being used for the right ventricle.
Yes, for example, color Doppler tissue velocity imaging, TDI, is commonly used to accurately assess RV systolic function, often by measuring the peak systolic velocity of the tricuspid annulus, a measure called S or TAPSE. This is important because the RV is often the first chamber to suffer significantly in chronic volume overload defects like ASDs or in developing pulmonary hypertension.
Now, the source also highlights that functional impairment isn't just about systolic pumping power. The heart's ability to relax and fill diastolic function is also a massive issue in this population.
Yes, diastolic dysfunction is incredibly common. Impairment of relaxation and filling capacity is prevalent in both ventricles in adult CHD patients, particularly in those who have progressed to more severe conditions with long-standing pressure or volume overload, or especially in those with severe pulmonary vascular disease like Eisenmenger syndrome, where the RV becomes massively hypertrophied and stiff.
And this leads to a really crucial distinction highlighted in the review, based on work by Vakunt and colleagues. The need to differentiate the types of heart failure seen in adult CHD patients. It's not all the same.
Exactly. This distinction is critical because it dictates therapy. On one hand, you have patients who develop classic HFrEF, or heart failure with reduced ejection fraction. In the adult CHD context, this usually stems directly from profound ventricular malfunction caused by years of excessive volume or pressure overload that eventually leads to systolic pump failure and chamber dilation.
And this group responds to standard heart failure therapies.
Generally, yes. This group can often be successfully managed, at least partially, using established guideline-directed medical therapies for HFrEF, things like ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, aimed at improving pump efficiency or reducing afterload and blocking neurohormonal activation.
Okay, but then there's the more challenging subset, the HFpEF patient's heart failure with preserved ejection fraction. How does that manifest differently in CHD?
This is the group where the primary problem is diastolic dysfunction. HFpEF in adult CHD predominantly arises from impaired diastolic function, often linked to that heightened ventricular stiffness and impaired relaxation we just talked about, perhaps due to that retained memory of chronic pressure or hypertrophy. The heart muscle itself might still be able to contract forcefully, hence the preserved EF, but it can't relax properly to fill adequately at low pressures.
And standard HFrEF therapies might not work as well here.
Critically, this group often requires different, more tailored strategies that specifically target the underlying diastolic dysfunction, like meticulous volume management with diuretics, controlling hypertension aggressively, managing arrhythmias, and potentially therapies aimed at improving relaxation or reducing stiffness, though effective options here are still limited. Standard HFrEF therapies might be less effective or even poorly tolerated.
So specialized imaging, including diastolic function assessment and maybe strain, becomes mandatory not just for diagnosis, but for actually categorizing the type of heart failure, which then directly defines the therapeutic strategy.
Absolutely. You need to know if you're dealing primarily with a pump failure problem or a filling failure problem.
This really underscores the necessity, in complex cases at least, of potentially using multimodality imaging, even though echo remains the workhorse.
It certainly does. While echocardiography is undoubtedly the primary choice for initial diagnosis, screening, and ongoing surveillance in the vast majority of adult CHD patients, due to its accessibility, non-invasiveness, lack of radiation, and superb dynamic assessment capabilities, we do rely on cardiovascular magnetic resonance, CMR, and sometimes cardiac computed tomography, CT, for complementary information in specific situations.
What are the main strengths of CMR and CT here?
CMR is superb for accurately quantifying ventricular volumes, mass, and ejection fraction, especially for the complex geometry of the right ventricle, which can be notoriously difficult to image completely and quantify accurately with 2D echo alone. CMR is also excellent for quantifying shunt volumes, QPQs, precisely, assessing complex anatomy like baffles or conduits after surgery, and characterizing myocardial tissue looking for fibrosis or scarring. CT is primarily used for detailed anatomical assessment, assessment, especially of coronary arteries, extracardiac vessels like the aorta and pulmonary arteries, and in patients where CMR is contraindicated. They provide crucial complementary data for planning interventions or managing complex postoperative patients, ensuring that truly comprehensive, tailored approach needed for these intricate individuals.
Our entire deep dive today, from exploring the subtle but critical differences in BAV phenotypes to the incredibly specific Singh-Sivakumar classification for guiding VSD device selection, and then delving into the nuances of differentiating HFrEF versus HFpEF in the context of adult CHD, it all seems to point towards one final unifying conclusion. Managing these patients effectively is definitely not general cardiology.
Absolutely not. The sheer complexity inherent in diagnosing, monitoring, and managing even these supposedly simple congenital heart defects throughout adulthood demands the establishment and consistent utilization of specialized, dedicated adult congenital heart disease ADHD centers.
And this isn't just about having the latest echo machine, is it? It's about the entire institutional framework that supports this level of precision care.
Exactly. It's about the expertise, the infrastructure, and the processes.
So thinking about the review's emphasis on this, what would you say are the key functions these specialized centers provide that a standard community cardiology practice often cannot reliably sustain for these patients?
Well, I think there are several key pillars. First, they ensure a seamless and knowledgeable transition of care from the pediatric world to adult medicine. These are lifelong conditions, often dynamic, requiring continuous expertise. A dedicated ACHD center prevents adolescents transitioning out of pediatric care from getting lost or receiving suboptimal care in a general adult practice that might lack specific knowledge of their unique post-surgical anatomy, their specific long-term risks, or the nuances of their hemodynamics.
That continuity sounds critical. And the multidisciplinary nature of this care also seems paramount, given the sheer volume and complexity of the imaging and clinical data we just discussed.
That multidisciplinary collaboration is absolutely essential. These centers bring together a core team of adult cardiologists with specific ACHD training, pediatric cardiological consultants, expert cardiac surgeons who understand complex repairs and potential late complications, electrophysiologists familiar with CHD-related arrhythmias, and crucially, imaging specialists, cardiologists, or sonographers who are highly skilled and experienced in performing and interpreting advanced echocardiographic techniques like 3D echo, contrast echo, and strain imaging in this specific population.
So everyone's speaking the same specialized language.
Right. That collaborative framework leads to highly informed, consensus-based decisions about lifelong risk assessment, surveillance frequency, and the optimal timing and type of intervention, whether it's medical, percutaneous, or surgical.
And finally, underpinning all of this is the necessity of vigilant, proactive, and advanced surveillance, particularly using echo.
Yes, this is arguably their central mission in long-term care. Specialized ACHD centers are equipped for and dedicated to vigilant surveillance. They utilize the advanced echocardiographic assessment methods we've detailed today, like meticulously tracking chamber sizes, quantifying valve function, measuring gradients, assessing diastolic function, and monitoring regional myocardial strain to detect subtle functional or anatomical changes potentially years before they manifest as overt clinical symptoms.
And that early detection is key to preventing irreversible damage.
Precisely. This early detection allows for a proactive intervention, maybe adjusting medications, timing a valve replacement optimally, or closing a residual defect, which can arrest the progression of late complications like irreversible heart failure, severe arrhythmias, or pulmonary hypertension. This fundamentally improves the long-term prognosis and quality of life for the adult CHD patient.
So, in synthesis, it seems echocardiography in the realm of adult CHD truly transcends its role as just a basic imaging tool. It really functions as a precision-guided instrument, empowering specialized clinicians to navigate the highly complex and individualized pathways of chronic volume and pressure loading, allowing them to craft highly tailored, effective therapeutic strategies based on detecting and interpreting often subtle functional and anatomical minutiae.
That's a perfect summary. It's the cornerstone of modern ACHD management.
Okay, so we've seen these incredibly specialized anatomical classifications emerge, like for BAV fusion patterns and the Singh-Sivakumar classification for VSD device closure, all driven by this push for precision imaging to guide structural interventions. This leads us to our final provocative thought for you, the listener. Given how personalized and functionally detailed imaging has become for specific structural defects, particularly in CHD, how quickly do you think advanced functional analyses like myocardial strain imaging, will completely replace the traditional ejection fraction as the universal standard for assessing cardiac function, not just in CHD, but across all chronic heart conditions. Is EF on its way out? Thank you for watching The Funnel Effect.